Assalamualaikum and very good afternoon. I would like to thank the committee for inviting me to give a lecture on secondary prevention and vaccination. When we discuss prevention of cancer of cervix, then prevention can be either primary or secondary prevention. And the primary prevention was actually involved the behavioral changes of the disease, and one of the important aspects. And of course, what we have discussed today, the HPV vaccination. The secondary prevention involved the screening, which can be either like the screening, the cytology, which can be a conventional or the team prep. It can be either be the HPV testing and then the real-time optoelectric device. This is usually involved in the universities. Okay? And of course, the molecular markers that was put forward previously. I'll put up here the UK National HPV Immunization, where they use the separate. The vaccination was given to the 12 to 13-year-old girls. It was started in the year 2008, and then the catch-up program will be with those within 14 to 18, and it already completed last year in the year 2010. And the first impact on first vital screening will be after 5 years in the year 2015, and the impact on CIN3 incident will be after 10 years of vaccination. And of course, the impact of death from cervical cancer will be in the year 2013. So where are we? We are just in the year 2011. And then our screening program just only started last year. And with all the issues that was put forward by the previous speaker, Dr. Muzamil put a lot of questions previously from the last slide. With all the questions, I think 5 or 6 questions that was put forward. The issue of vaccination per se comes in. The issue of screening is what we have gone through this morning. There is a lot of issues on that perspective. And furthermore, the ongoing study. The ongoing study, what I mean was actually the study by Cedric of Gadasil on the perspective that when they give the vaccination, they're going to check the titer. And then from that, they're only going to finish by the year 2013. So there is a lot of issues that we didn't know. There is a lot of outcomes that we are not sure of. And furthermore, we are talking about secondary prevention. So the answer was actually, I don't know what is the answer, to tell you the truth. It's totally different if you are talking about, you got CIN3, what needs to be done. It makes it too easy to decide, okay, ablative therapy. But constantly prevention is very difficult. But what I'm going to do was actually, I'm going to recapitulate back all the speakers that have presented this morning, and then from there, where are we, and what is our futures, okay? What is important? Whether vaccination or screening, or either screening or vaccination, or both. I'll put it up, we need HPV vaccine to significantly reduce the healthcare burden currently required for cervical cancer treatment. There is no doubt about it. Okay? We need screening because of the limitations of current HPV vaccine, both in their lack of curative effect, does not protect women on ongoing nuclear process, and of course in their limited number of HPV types. We have only 2 types, 16 and 18, and then we have at least about 50 or more than that of the oncologic type that can cause the cancer. And of course, because of this, we are living to involve some 20 to 30% of cervical cancers that we are seeing. Okay, but you shouldn't be worried. There is a lot of ongoing study on this. Okay. However, the answer only applies in scenario in which screening is already efficient. We know that a well-developed screening program, of course, the incidence of cervical cancer will be very low, such as in Sweden or some Sweden. And moreover, should polyvalent vaccine dose include some 5 or non-HPV vaccine? There is a study going on by Gadase in US comparing the quadrivalent with the 9-valent vaccines. They are doing these studies, okay? That may result in excellent protection against more than 90% of the oncogenic HPV types, and vaccination alone would be the answer for both scenarios. Okay? So, although the question was actually vaccine or screening, I think a complete answer to a fairly straightforward question. So, where are we? And because before this will arrive, I think the most important thing, what we have gone through this morning about HPV testing, I think the issue was actually the cost. I was told that one HPV testing will easily cost easily about 150 to 200 ringgit, and of course, especially in the government hospital, maybe they can decrease to at least about 70 to 80 ringgit to do the HPV testing. And of course, you have the 4 companies that was involved, and then it's for us to decide which one we're going to choose, and furthermore, how sensitive, how specific it is going to be, and how low cost they're going to give it to us. If it costs only 20 ringgit, I think that's quite reasonable to do HPV testing in all of our population populations. Okay? So because of this, we're still having the same current management, put it that way. We screen and we treat. Okay? If we are looking on HPV vaccine and screening programs with this era that we put it out as vaccinations era, I think with the scientific knowledge of HPV infections, I think there is a lot of things that we gain from there. Of course, we know about our HPV testing, we know about our HPV vaccination, and then with these 2 issues that was put up related with HPV infections, I think this leads to the change in the strategy of secondary prevention, and of course, in some of our management in our CIN cases. So where are we now? Currently, we have both the vaccinated and the non-vaccinated female population of cohort. And of course, with this, we know that our screening psychology protocol will keep on changing with the next few years, with the issue or the outcome of all the other studies, ongoing studies. And of course, the most important thing is what Dr. Maimon has put forward. We really have to have an effective introduction of HPV vaccine. Although we are having 2 vaccines in oncology, but we have to wait for the studies where in US the 9-valent vaccines. So this is still the issue. That's what put forward by Dr. Maimon. Okay, how good of the current screening program in the sense of sensitivity and specificity? What are the acceptance of the HPV testing? Acceptance of HPV vaccination. I think the issue of completeness of full 3 doses is very important. I think the latest issue in ACOG in June was actually they have conducted the study back in US, but it involved only about 1,000 plus of patients. And those who really who managed to complete within 12 months was actually only 33%. And this was actually involved those opportunity vaccination. We are not looking on the perspective where we are looking at organized vaccination where it involves those in the between 9 to 11 years girls. And then, of course, the global organized vaccination and screening program, the issues on that, and of course the secondary prevention issues in each program on the perspective of durations. On screening, let's say we screen the patient involving HPV testing. If it was negative, what will we do? Do we need to screen in the next 3 years, or do we need to screen in the next 5 years or 6 years? That's a further issue. and of course the frequency in the screening that involve the pap smear. There's no doubt that effective screening program will be prerequisite for evaluation of vaccine effectiveness. There's no doubt about that. Vaccination and serology screening will complement each other. And then, if you are looking back on the global prevention programs, the perspective of HPV immunization integrated in serology screening is viewed as an important breakthrough in our public health. There's no doubt about that. But another issue came in. How to most efficiently carry out such global prevention of cervical cancer is still not clear. I think that was the reasons that we are here to discuss and to postulate what is going to be our secondary prevention programs or in the future. The goal for the prophylactic vaccine was actually to reduce and contain the incidence of HPV-related disease. And of course, we need to know how important is our HPV vaccination. And the other issue is the long-lasting human response. This is the issue whether we need to give the booster or not. Although, from what Dr. Muzammil has put forward for the last 7 years, I think the antibody was still high, at least more than 6-fold higher compared to the natural infection. Okay? The issue of organized vaccination programs, this is very important. And then, at the time being, I think I was told nearly more than 100 million was already being given HPV vaccination, more than 100 million. Okay, although some issues remain unresolved, as was put forward by Dr. Mami just now. Now we go to the screening systems, because if you look back on the perspective of secondary prevention was actually involved the screening issues. Screening to detect early CIN changes, and then the treatment that needs to be given. Treatment-wise was quite clear forward, then I think that will be discussed tomorrow. Okay, so the need for continuous screening for vaccinated women is related to all invasive lesions, not include exclusively generated by HPV 16 and 18. 16 and 18 involve only 70% of the cases. If you add in 31 and 45, it involves at least another 80s, and if you have involved all the oncologic screening for at least about 9 to 40, it involves more than 94% of the cases. Okay? And the issue of cross-protective benefit is still to be definitely proven. Okay? And the duration of both vaccines has to be evaluated and monitored through vaccination programs. And of course, the optimal vaccine benefit is demonstrated in the naive adolescent young women. This is actually what has been put forward. Okay? And as what you know, that when you are discussing about screening program, women is still the women. Women, of course, can't be a man. And then women will always be worried. That's definitely a worry. If you decided that you're going to do HPV testing as one of the screening program, besides cytology, I think if you got HPV testing negative, if you told the women, can you come back and see us back in the next 5 years? I don't think women will wait for 5 years. Definitely they will. They will be very eager. They will come back to you in the next 3 years, the longer it takes. Although, as what we are facing now, those women that we do a pap smear, we told them they are negative, they keep on coming the next 1 year to do a pap smear. I think this is reality. This is reality. I think there's another issue on that. That's why I put up for most legal women today, screening remains their primary options for cervical cancer. But I think they are right on it, because if you are talking just on cervical cancer, I think you should take the opportunity when the women come and see us, not only for cervical cancer program, but I think you take the opportunity on this time, do a proper vagina examination, do a proper ultrasound, and of course, have a chance to check the breast together. I think that's another issue on that. So it means that they are coming for the screening, we are screening all for the women, especially those that related with our gynecological problem. I think that's fair on that perspective. And with these issues, I think for us, we need to anticipate that the screening cytology protocol will keep on changing in the next future. So it's still not fixed on that perspective, because we are still having the vaccinated, we're still having the non-vaccinated women. Okay, and we know that today early in the morning we are moving our prevention model based on cytology, colposcopy, histology to the biomolecular model. And then the biomolecular model HPV testing, we are looking on the perspective just now, all the drugs that was put up this morning, they say they are almost sensitive, HPV DNA test almost 100%. So because of that, I think if you use the most sensitive test to detect life-threatening HPV infection as an upfront tool to identify all women at risk, I think HPV DNA testing is actually very sensitive from that perspective. But it's not as specific as a PET test. So because of this, the HPV test, DNA testing must be followed by the specific test of the PET test, and this can be used as a triage to avoid unnecessary referral for our colposcopy. I think that's a big headache for Mozambique, because he's more interested in the CIA changes. HPV DNA testing we have gone through this morning, I think that was quite clear, the sensitivity. And then I think that the clinical application was true as a price for women who are having the equivocal cytology ASCAS. If you got equivocal ASCAS, I think that yes, it's true you need to do HPV DNA testing. And the other thing was actually HPV DNA testing can be used as surveillance after the therapy that was glucose ion changes. And then I think if you're going to advise HPV testing, you can do that for those women over 30 or 35 years of age. And we know that with the low incidence of CIN changes in those HPV DNA negative women, sometimes we can suggest as a preventive strategy in these women that they may be screened for every 5 or 6 years. I think there is a protocol that was put forward by the company that was given to you. I think they were advised if the HPV testing was negative, the patient can come and see or check in the next 5 years. Okay. Contrary to conventional cytology, I think HPV test will still maintain its performance also in population with low HPV prevalence as a result of vaccination. We will highlight after this. And I think you already know that the rationale of using HPV DNA testing for second prevention like cancer, as what I put out for the trials, and in the morning also you realize that the dramatic impact of cytology-based better screening when you include the HPV DNA testing. So I will go into detail about these, and then you have knows about the accuracy of HPV testing. And the need for global prevention strategy, I think there is a lot of main challenges around. And then the challenges was actually how we're going to combine these preventive tools, the primary and secondary, and then how we're going to optimize this overall cost of this new global strategy. I'll put out that the cost of vaccination will be balanced by savings of reduction in disease incidence, less diagnostics and therapeutic procedures. But if let's say you assume that 90% of efficacy of the vaccine for the next 10 years, and with the coverage of 100% of the 12 years girls, and with a binary screening beginning at the age of 24 would result the most appealing cost effective. It's definitely about that we know about this then. And as what I told, the rationalizations of new screening strategies in low HPV prevalence setting for HPV vaccination may allow to reduce the costly screening program. The reason they put out there, different age of starting screening, lengthening the time interval between screening around, modulating proper timing between vaccination and screening, monitor the long-term effectiveness, consider adverse events, and increase prevalence of other genotypes as a result of the replacement phenomenon. I think, although we are checking for the, we have to check. We are still not sure whether although we are having about 15 oncogenic virus, subsequently after that you are getting other type of oncogenic virus. And of course, the other thing was actually the geographically, as what we put up this morning, that our incidence of 52, 58, 48 is increasing back in Indonesia compared to other countries. So this is what the American Cancer Society put up to clinical vaccination. I think most of this was actually put forward by Dr. Muzame and Dr. Maimu. Okay. And then the other issue was actually any changes in our cervical cancer prevention policy with or without vaccination have to be addressed to all the women. I think this is very important. If it's not, then as what you realize that there's going to be a high disparity among various social cultural layers of female population. This is true, especially if you are putting up vaccinated, you are putting up those opportunistic vaccination or opportunistic screening program. Okay. And another scenario was actually those patients who have been vaccinated. The fact that the false sense of safety produced by vaccination. If they felt that they are fully protected by the vaccination, I think they are less likely to participate in the screening program. I think we're going to lose that. I think there's an issue there. If let's say that 50% fewer came vaccinated Pacific over a 5 years period, I think we're going to lose easily at least 4 to 6 of CIV to CIV changes among 100 women. There's another issue on that perspective. Okay, the HPV vaccination program, I think, that has been put forward by the issue by Dr. Muzame and Dr. Maimu. I don't think so. I need to go through these. And then I think the importance of the cross-protection and speech-track replacement, I think there's another issue on this perspective. And then the issues that was put up, vaccination efficacy in men and high-risk subjects, as what that Prof. Hatta has put forward. I think the most important thing, if we are looking back on this, although the proper way to combine primary and secondary prevention into the integrated program remains to be defined. The potential of this global strategy is to complete the goal of cervical cancer in the next decade. I think we will be there. Definitely will be there, whether the next 10 years or the next 20 years. Okay? And then if you are looking back at cervical cancer prevention method, I think the vaccine is the primary prevention, and hopefully from the bivalent or quadrivalent, as what we're going to have the 9-valent or the polyvalent that we're going to get in the next future. And then if you are looking back on secondary prevention, I think most of the issues that was put up on the screening, pap smear, TIM pride, HPV testing has been put forward. I think that should not be the issue about treatment. The treatment was actually been there for any problems. Okay, I think if you are looking secondary prevention as a whole, I'll put out secondary prevention involved interventions to detect and stop the progress of the disease during earlier stage. Okay, we know about cervical screening program. We know about interventions. I'll put up here the organized screening program or organized prevention programs as what we put up. We know that the issues, the problem of having opportunities screening method, and then we know that what's happening, the organizing will always be there in developed countries, and the opportunity will be there in the developing countries. We are facing the issues, that problems, okay? And we know that the disadvantage that was put up about the opportunity screening program just now, and then I think we know that the issue of the pap smear, conventional smears, and then the issues of combining them. This is the whole study that we've been done. If we combine, we can almost have the sensitivity more than 95%, although we are getting more than 95%. Okay, and if you are looking at the main HPV vaccination has been put forward by Prof. Hatta, but I'm going to touch that vaccinating males not recommended at this time, although it's very recommended in the US. Okay, if you are putting the strategy achieving coverage of more than 70% in the primary target of young adolescent girls are expected to be more cost-effective than vaccinating mixed populations of girls and boys. I think that was put forward after the discussion since 2009 as what Dr. Maimu has put forward. Okay, and the more they have shown that under assumption of equal vaccine efficacy in girls and boys, increasing vaccination coverage of girls is always more cost-effective than extending coverage to boys. The issue was actually the release of the quadrivalent vaccine, the anogenital wars. I think that's another good point. The need to vaccinate the boys. Okay. As a summary, second prevention of cervical cancer via cervical screening is important. There's no doubt about that. And vaccination, that's what we are having facing now, HPV 16 and 18 offers primary prevention against more than 70% of cervical cancer. We are hoping to have a polyvalent where it covers more than 90%. And then the most important point was actually HPV vaccination does not eliminate the need for screening later in life for disease due to other oncogenic HPV types. And then I think another issue was actually we are talking about prophylactic vaccine. That's what we put forward just now. I think there is a new studies have been studied for the last 10 years about therapeutic vaccine. I think there's new perspective of therapeutic vaccine will be coming in. And with that, I think of course there will be changing in the secondary prevention, there will be changing in the HPV programs in the next future. We cannot run away from that perspective. Okay, let's open our mind on that issues. I think the other issues about changes in colposcopic practice brought by HPV testing. I think if the HPV testing was positive, all patients come for colposcopy, there will be a big burden on that. I think there's certain issues that will come up from the HPV testing, because as what I'll put up here, HPV testing advantages was actually it's highly sensitive. Okay, HPV testing can be used to confirm cure after treatment, as what I've told you just now, and of course it can be an adjunct to cytology and histology diagnosis. The colposcopic evaluation and guided biopsy is still really critical tools, and from this perspective, I think we have to have another workshop. I think the Mission Gynecology Society must have a regular workshop on that, yearly workshop to cover on these issues going for every state, because I think what we have been doing the last was actually only in Terengganu. I think it has to go for every state in all the prevention program for cervical cancer going to be successful, okay, to be 100% successful. Okay, and that's the reason I'll put that a long-term and accurate monitoring system is very important, has been put forward by Dr. Mozame just now. And the most important issue now, what we got it today, was actually the concept of screening. I'll put up after HPV vaccination should drift over time towards a generalized adoption of new generation screening protocol, okay, largely based upon detection of HPV DNA. We know that we are changing from 2, 5, 9, and the polyvalent, the number of polyvalent that we are not sure. And however, current scientific evidence really recommends to us that first-line screening tests are the most sensitive. There is no doubt that HPV DNA testing is very sensitive. It's almost 100%. And to use the most specific that we cannot still run away the cytopathology for the trials of diagnosis. So it means that HPV DNA testing and cytology has to come hands in hand. They cannot say that the drugs company, the drugs manufacturer felt that HPV testing is the one that you have to go with. No, it has to come hand in hand. Okay. Our main ongoing issue is still there. The complete evaluation of impact of HPV type-specific cross-protection is still there. That we're not sure. And then the other thing was actually advance in the evaluation of sustainable alternative for screening in developing countries, and advancing model for the integration of HPV vaccine, and in the definition of subsequent the screening programs for surveillance of affected women. We cannot run on that perspective, and this is a research that has been put forward, as what I've told you just now, about high-risk HPV type is still on research, and then Galaxy is with the research on the comparison between the quadrivalent and the 9-valent, okay, and the research on the therapeutic vaccine. I think they were coming up on that issues, and then as an overall conclusion, as what I put out here, and then partly has been put forward, I think it's important that screening continues to coexist with vaccination for many years. Thank you. I think the most important thing, I think prevention of cancer of cervix is better. Thank you. Okay.